Hi everybody, I'm happy to be here again in our new podcast. Today we will talk about a different type of abnormal fertilization. We will focus on fertilization where there is some doubt regarding its abnormality. About 10% of inseminated oocytes are abnormally fertilized. As we have discussed in our previous podcast, 3PN zygotes are considered to have a polyploid chromosomal content originating for diandry or digenic fertilization. In this case, there is a risk of miscarriages and molar pregnancies. For that reason, they should not be transferred, although different studies have previously shown that considerable proportion of them are diploid. A small proportion of the fertilized oocyte represent 2.1 pronuclei or 2.1 PNs. These zygotes consist of two normal equal-sized pronuclei with an additional very small or micro pronucleus. Even though it is considered a rare phenomenon, when we meet 2.1 PN differently than 3PN fertilization with equally pronuclei size, we think twice regarding its normality. Let me ask a few questions. Is this type of pronuclei appearance considered normal fertilization? How do we know if the micropronucleus consists of an additional set of chromosomes? In cases where this is the only embryo the woman has, shall we transfer or not? I would like to show you a video of 2.1 pronuclear fertilization. In this video, you can see a small pronucleus in addition to the two normal-sized pronuclei. In this case, you can also see two vacuoles in the same size of the small pronucleus, however, they have different structure. The small or the micropronucleus contains nucleoli and disappear at the same time of the two normal-sized pronuclei. The embryo develops into a good morphology blastocyst, although originated from 2.1 pronuclei. You can see the blastocyst expansion and the beginning of the hatching. The question is, what is the source of the micropronucleus? In a study published by Hiromi Takahashi and his colleagues, they demonstrated important results. Firstly, the additional smaller pronucleus was formed later than the female pronuclei. Secondly, the female pronuclei of the 2.1 PNs were smaller than those of normal 2 PNs. According to these findings, they suggested that the additional smaller PN may be derived from the lagging chromosomes, which appear during chromosome segregation at the time of the second polar body extrusion. Using PGTA have demonstrated that blastocysts developed from 2.1 PN were mostly diploid, and few live births were achieved from this transferred blastocyst. However, most of the 2.1 blastocysts were aneuploid, presenting extra or absence of specific chromosomes. The question is whether to transfer or not. In cases where no other embryos are available for transfer, patients should be informed regarding the low normality rate of 2.1 zygote prior to the embryo transfer. In my opinion, such embryo transfers should always be performed following PGTA. In our next podcast, we will talk about one pronucleus fertilization and its clinical implications. Stay tuned.